Thank you, Cory. That was really interesting. And so we already have a few questions coming in. So why don't we dive into that? And then everyone feel free to put some more questions into the chat as the question and answer goes. So the first question that came through was, can you take us through the progression of muscles you did IMS on throughout the plan from your case, please?
Sure. Basically, she came in, I did an assessment kind of throughout her entire body, and it appeared that the muscles of the cervical paraspinals seemed to be the most tight, followed by some of the lumbar muscles. So the early choices, I've got the sheets right beside me, but I think I did 2 spots in the lumbar paraspinals at somewhere around L4. And about 4 spots in the cervical spine, or 2 to 4 spots in the cervical spine paraspinals in and around the area of C5 and C6. The assessment findings actually replicated some of the radiologic findings, so that was neat and tidy, and it isn't always, but in this case it was. So that's where I started. The needling continued as I was getting kind of positive feedback that the amount of needling I was doing was not too much. So as the sensitivity of the nervous system drops, I can increase the number of points. And as I said, it was up in and around the area of 24. That's not like a cookie cutter way of doing it, because I think I would classify myself as quite a shallow needler. And I think that I do that on my hypersensitive people, because the deeper you needle, the more sensitive and the more stimulation they get to their nervous system. So 24 points might sound like quite a few, but these are not, like 24 points when you're going super deep and really kind of impacting a lot of the stretch receptors. So that would be the progression. And I would say we did, I think, somewhere around 16 treatments, and the apex of the number of points would have been neatly right around 8. Like, it was actually, it followed that kind of red to yellow to green graphic that I had provided earlier in the slideshow. Hopefully that answers the question.
Matthew, did you have a follow-up question?
Sorry, I just have to take myself off of mute. No, that answers the question. Thanks. Well, do you sort of typically get into the levator scapulae, the rhomboids, when it's related to the neck?
Yeah, that's a very, very common destination for me. So yep. I generally start with paraspinal muscles. Yep. In keeping kind of with a theoretic model. Yep. I add some of the peripheral ones if the central ones are too sensitive, or at times if they seem to be very important to the client. Like I said, with this client, she was very actively involved in steering her care. And on one hand, I wanted to keep her educated about what probably better strategies would be, but I also wanted to maintain a good therapeutic alliance and see that she could see that I was listening. So in the pain science world, when we look at rumination, magnification, and catastrophization, we often think that those are byproducts of people that don't feel well heard. So right. If they tell you that their pain's a 9 out of 10 and you're not doing anything about it, they naturally tell you it's a 12 out of 10. So sometimes I migrate some of my points a bit peripherally, specifically for the client. So I'm cautious to answer that question in a general sense, but in this client, I definitely would have done lev scap. I definitely would have done kind of some of my favorites are infraspinatus and supraspinatus at that C5-6 area. Yeah, I did not go further down into brachialis and biceps in her. I could have if some of those other points were contraindicated due to procedural soreness, but in her case, I didn't. She actually, interestingly enough, was a very easy client to treat. She was 100% on board. And when I originally did the assessment and reviewed some of the assessment paperwork that came in from the orthopedic exam, I was actually expecting someone to be a bit more bullheaded. Right. Again, I think that maybe she was more of a leader because I think she felt poorly coordinated. Right. Where when Dr. Jelena changed that by giving her a very coordinated plan, and then she met me, and I'm all about listening to the client. I think a lot of those things naturally fell to the wayside, and it was actually a very easy client to deal with. Yeah.
Yeah, I think the the individual motivation is very important. Yeah. But thank you. Go ahead.
So I was just going to say the therapeutic alliance, I think, is like, if I have a small superpower, I think it's probably my therapeutic alliance. And then some of the literature I'm reading right now and some of the podcasts I'm digesting are like nocebo and placebo. And I always joked in physio school that if the placebo effect was 24%, then I for sure was going to get 24%. And some of the literature coming out right now is really, really pushing people to make sure they're not just getting, you know, the additional 14% on the placebo that a little red pill will give you. Make sure you're also getting placebo. And again, I just think that's a matter, I think that placebo is a lot of that client expectation, and that client expectation is influenced by how we educate them. And the more we educate them that we expect physiologic success, I oftentimes show people by scratching them. I predict what's going to happen. I predict that redness is going to come, and I predict how long it's going to take for that redness to go away, just to demonstrate them to them that their physiology is indeed working. And we're just going to be working on a couple of the things that have become misaligned in this kind of what I call a hyperarousal, fear-based state.
Yeah, brilliant. Yeah, I think that therapeutic alliance is key, and also the education component.
They go hand in hand. That's a great question. Thank you.
Yeah, thank you.
Great. And the next question just follows right on actually to this concept of the placebo and the therapeutic alliance. And it's maybe we don't need IMS. Maybe the mechanism of IMS works perhaps by contextual, placebo, diffuse, noxious, inhibitory control, priming of clients, and the fact that it is invasive and has a twitch response, which can change beliefs. These things are hard to control in studies, that's for sure. And this is where Travell and Simmons failed in thinking. So what are your thoughts on that?
So when I did my clinical specialist, so let me back up. So I started as a Travell and Simmons trigger point massage type physio with a lot of activity based. I mean, I've always been very activity based, and I found that to be very effective. I took my Gunn IMS course quite early in my career, and I had already had kind of an inkling of which clients that I could deal with and which ones I could not. And what I expected to do was to take the Gunn IMS course, maximize my usage of it in about 5 years, and then I was going to go on to the next thing that I was going to add to my toolkit. So here I am on year 27 of my career, and I haven't abandoned IMS, and in fact, I just seem to figure out more and more applications for it. So when I did my clinical specialization in pain science, and of course we get this very kind of neuro-orthopedic institute, you know, Butler and Moseley model, that's of course exactly what I was thinking. And from the compassion side of me, even when you do needling well, you know, it's a needle. I mean, I don't use the term needle after the assessment. I also don't use the term depth. I use the term treatment and thorough, because I want to, again, honor kind of how loaded those words can be. And I always thought after my clinical specialization that I was going to be, again, learning more emotional and behavioral modification techniques, relaxation techniques, you know, body scans that were going to eliminate the need for Gunn IMS. And I had no problem with that, but it hasn't happened. And I would say these days, 50% of my referrals in clinic are for pain science education, with absolutely no talk about Gunn IMS. This one was interesting because they specifically mentioned Gunn IMS as a potential. And in the people that I do my pain education work with, if they are getting better and making improvements, but hit a stumbling block, I kind of naturally do a neuropathic exam in all of my observations. I can't stop it. I even do it, you know, when I'm shopping at the grocery store. So I'm always aware that these people have something additional going on, but I want to let the pain education take its course. And I would say 80% of the referrals that I do get for pain management education programs, I end up doing a component of Gunn IMS. So yes, I agree with you. Maybe people that are better at the application of the pain science stuff or do it different than me will have different successes. But I continue to go to that Gunn IMS well. I'd like to have greater conversations in forums like this about why that is, because I haven't reconciled that myself. I'm still currently a somewhat educated observer of what's going on. And again, as you saw from my presentation, I really want to let the client's belief system guide what I'm going to do. And it is absolutely hysterical to me how I end up having these chronic pain people that do so well. And as they're going to be leaving, I'm like, like, why don't we maybe try this one thing? And then boom, it takes a jump. It is still very important is all I can say, but I completely appreciate and digest your comment and agree that it would make sense, but I haven't seen it yet. So interesting. Talk to me in another 5 years. We'll see what happens.
Yeah, you see it a lot, and just the way you're saying, people feel that they're not heard, but if you're in a room one-on-one with them, needling them and stuff, you are going to have a chance to listen to them as well. Okay, so the next one. Were your early choices of IMS locations more proximal to C4-6 or more distal? What factors did you consider to decide on those first 4 locations?
Yeah, so they were more proximal, and the more proximal was again just kind of appeasing the theoretical framework that we wanted to get these paraspinal muscles to release, because the tension on the nervous system in this case, she was hyperlordotic in both the cervical and lumbar spine. That adds a compressive force, and that created the irritability of C5-6. I'm sure her brachialis, brachioradialis, her deltoids, her supraspinatus, infraspinatus could have all had shortened muscle syndrome, but if I had treated them by themselves, my release of that lumbar kind of oriented compression on the spinal nerve root wouldn't happen as quickly. It would still probably happen, but not as quickly. And I did, in my early years doing IMS, I did quite a bit of peripheral needling, I think because I had that Travell and Simmons background. And when I phoned Dr. Gunn on a client that was actually a C5-6 client, I was stuck on this person and it didn't make sense to me. And he very politely said, Mr. Choma, would you possibly consider doing the paraspinals? And I think even though it was on the phone, I think I turned beet red and I was like, oh my goodness, I can't believe I didn't do that. So I always start with the paraspinals. When I start with the peripheral point, it is because of client preference. I want to get a good therapeutic alliance, or because maybe there's a skin condition. I get some people that are a little bit rashy because of other medications that they're using. And so I might have to come at those paraspinals later. I always start with paraspinals unless I have to start away. So I hope that answers the question, but it's always as a result of the assessment findings, and the assessment findings in the Gunn IMS framework really concentrate on the paraspinals as the source of that minor compression to the peripheral nerve, impacting supersensitivity, as it was called back in the 60s.
No, that's marvelous, Cory. Thank you very, very much.
Okay, and then there was a link posted just where you can get some of the resources from the Pain Made Easy program. And while we wait to see if there's any other questions, I'm just going to ask, Cory, do you have any tips for because some people still are quite jumpy, when they're getting needled. Is any sort of technical or pro tips that you can share around that?
So you mean jumpy on the insertion of the needle, like a local twitch response?
Yeah.
Yes, so I have 2 things to say on that, and this is probably a broader question we should have with the instructor group to make sure I'm consistent, but as always, I'll just put my opinions out there and we'll discuss them later. There was a paper that came out a couple of years ago, and I can't remember the title exactly, but basically it said, is the local twitch response required? And the summary of the article was that yes, for better response, it's required. I 100% absolutely disagree with that study, and I think that it was biased by the idea that a local twitch response is an objective thing that you can see tangibly and you can measure. But if you take a step back from that jumpy muscle and you instead look for signs of a heightening arousal of the nervous system or a diminishing arousal of the nervous system, then you can actually treat the exact same muscle without having to treat it high enough to get a local twitch response, which is why I had said in an earlier answer, I'm probably somewhat of a shallow needler compared to what many people are used to. And that's because I would rather win a dart game by getting triple and double scores rather than always going for the bullseye, because I think that that's linked to client comfort, and the client comfort, adding some modern pain science terminology, would influence their perception of fear. and their experience of fear. And again, from a nociplastic pain point of view, fear is the fuel of nociplastic pain. So I'm always doing everything to diminish that. And so I don't always go to the local twitch response. I purposely try to avoid it in the early treatments. And then as their sensitivity drops, I'll discuss it with them and I'll say, hey, I'm going to do this point. There's going to be a tiny twitch, almost like when I tested your reflex on your knee. And then I'll do one, I'll stop, I'll put my hands on them. I'm like, I could see that muscle twitch. Did you feel that muscle twitch? And they're like, oh yeah, it did. That was different than before. I'm like, that's a higher order stimulation, which I'm doing right now because your nervous system is doing so well. Is that okay with you? And so that's kind of how I approach that. From the point of view of actually inserting the needle, then again, I use that dartboard analogy. If you insert that needle into the bullseye, you're always getting bullseye points. I don't care how you do it. But if you go a little bit superficial to that, you're still getting a level of stimulation, but you're not going straight to the bullseye. The way I explain this to a patient is I show them patellar reflex, and we take our reflex hammer and we hit them, and it's a very quick movement that elicits a reflex. And I say, you're aware of this. Like every time I hit you with a hammer, what that does is it compresses this tendon and lengthens it out, and it causes a reflex. Do you agree? And they say, yes. And then I take my fingers on that tendon and I slowly compress that tendon and lengthen it out 3 times more than I would have with the reflex. And I say to them, why is the muscle not jumping now? And they're like, well, I don't know. And I'm like, because we didn't elicit a stretch reflex. We kept the amount of stimulation below the threshold required to get that reflex. That's what I do in needling. And I always find little things like this are very poignant reminders for them that really we're just acting on the nervous system, and that we can always do these. I always call them biohacks. So the pro tips you're saying, I always call it a biohack because that's a very common term used in Instagram and other podcasts that I digest. So I want to use common terminology, but hopefully that answers the question. I go in slow. I don't do a lot of moving around the needle. I don't force the local twitch response, because that study that we've all read, that could be a whole topic at another time on why I think that the results of that study and the conclusions are biased. But I don't think the local twitch response is required. And it can be quite painful for a person with a hypersensitive nervous system. So probably good to stay away for the first couple of treatments.
Great. Okay, I have another one, Cory. When would you choose to take an IMS-centric approach, and when would you choose to take a more traditional pain education approach?
So the first kind of consideration would be the referral that was generated. So I get a lot of referrals specifically to come to me as like the human being, the physio, and depending on where they come, they will have a certain expectation. So as a part of all of my assessments, I asked them what brought them to me specifically, as opposed to one of the other, decent options around. And then I asked them, what are you expecting that you're going to get from me? So typically, if a person comes in from a pain science point of view, they'll just say, I don't know, I was told you do some program. And I said, like a program that included education. And then we're thinking, the pain made easy format. Sometimes, like the new assessment I did today, the lady said, I'm already going to a massage therapist. She said, I have to come see you. The stretching that she was doing is the only thing that's been effective so far. And she said that you're going to do something that will complement it, that includes a needle. So then that's kind of my jumping off point, that I'm going to head toward the Gunn IMS. I did explain to her today. So her pain started 18 months ago when her husband and running partner suddenly and unexpectedly passed away. It was stated by her as an intense trauma. And now every time she tries to hurt her knee hurts, but no therapist she's tried for can find a smoking gun. And I said, would you be willing to entertain that perhaps it could be a little bit up the chain in your nerve rather than down on the knee? Because we pressed around on the knee, we didn't really find anything. And she said, well, I've tried everything, I'm willing to hear you. So she came in for IMS, I added pain science. On the lady that I did the presentation today, she came in for the pain science. In that case, I added IMS. I would say that 70% of the clients I see will get IMS at some point, and 100% of the people I see will get pain science. Like, I mean, I can't avoid that. That's just a way of teaching people that the pain they feel is a warning sign and a call to action. And it is a positive in the body, not a negative. And if we can unpack it, it always makes the pain better when you unpack it and you remove the fear. Hopefully that answers that question.
Yeah, no, I think it really does. Okay, next one. Is it your opinion that there's a correlation between the pain evoked by the needling of a certain muscle and the magnitude of the underlying pathology within that muscle? I.e., is a muscle that hurts more during needling likely to be worse off than one that hurts less?
Yes, like easily yes. I think that so pain is an output of the brain, and that output is initiated by peripheral inputs from the tissue that can be augmented. I always describe it as a dimmer switch. So there's a dimmer switch at the tissue. There's a dimmer switch at the neuromuscular junction. There's a dimmer switch when it gets to the spinal cord, when it crosses the spinal cord, when it gets up into the brainstem, and then of course when it gets to the brain for processing. So any one of those points, it's possible for your body to turn that pain up or down. And when you are needling a person and they are experiencing more pain, again, that pain's an output. So that input that you have is being turned up with that dimmer switch somewhere or in multiple places along that route from the tissue up to the brain. And so that is a byproduct of what I currently use the term hyperarousal, but as I mentioned, the older literature, supersensitivity from like the 1940s and 50s, the term hypersensitivity, which is more like 80s, 90s, early 2000s. I start to use hyperarousal. In this case, I think they're all the same, but a tissue that's on fire will send more impulses up to the central nervous system for processing. And what I notice with people is that if I start with a lower amount of needling on that hypersensitive tissue will diminish and they will be able to handle needling more. I have a world-class pole vaulter right now who is also a cancer survivor and has a very, very hypersensitive nervous system generally. And when I started seeing him, like I don't see him often, I see him whenever he has a problem, but when I first started seeing him about 5 years ago, we would do 2 needles, tap only. So that's like a 3 millimeter insertion. And he is drenching the table with sweat. He's getting all hot. He's vasovagal. He's having all these feedback mechanisms, but at the same time, his muscles are releasing and he feels better. When he was in today, he was laughing and he said, I can't believe how much needling I can handle compared to before. And that's because that hypersensitivity is diminishing. So in my books, regardless of which dimmer switch is increased or decreased along that nerve line, higher sensitivity in tissues is always a byproduct of a tissue that is more involved. And in the Gunn IMS model, if you look at the law of denervation supersensitivity that's put forth by Cannon, it is the level of supersensitivity is at its highest in exactly the area of the tissue or distribution of the nerve that is the most compressed or elongated or tractioned. So the two are like 100% related.
Great. And then a follow-up question to that, Cory, does the muscle actually relax? Are we pathologizing trigger points? Or maybe we're just changing the perception of stiffness and pain, and by saying these points are your source of pain may actually increase their pain in a ruminator. Is IMS just pain modulation?
So do the muscles actually relax? I mean, from the point of view of assessment and reassessment within a treatment, me as the practitioner and the client notice that they do. Now we can get into a bigger conversation about what was the stimulus and how much of a stimulus it was. That is the placebo talk. So when a drug gets tested for market, what they'll do is they'll say the effect of this drug was 30% above placebo. Nobody ever talks about the total effect. If the total effect is 65%, then placebo was 35%. And so we would give that drug seeking the 30%. What I would say is I want the full 65%. So I don't know if we can tease out how much of that effect is the IMS, how much of that is the therapeutic alliance and the use of terms that we have, and how much of it is a true placebo effect on the basis of their expectations. But I think they're all at play. And, Lyndall might be a better person to talk about this because, of course, she's completed her PhD, and maybe she would be able to pipe in on can we actually divide out this kind of conglomeration of inputs to the brain and be able to tell which one is acting? I don't know. I think that these are really, really fun conversations, but when it comes to the client on the table, they are a byproduct of all of them acting simultaneously. So that's when I give my analogy that science loves to cut things up and try to divide them out. And I'm like, I don't know, man. I go out in the mountains and I just observe the beauty. I'm not saying like the rock is beautiful, the sky is different, it's 30% beautiful, and those trees, my God, those spruce trees are awesome. I'm just like, it's just beautiful. So the scientific people are all like, yeah, I can't believe you just said that. But I don't know if that's discernible. But I do know that I have a practitioner that works with me. We've worked hand in hand for 10 years. She is way more aggressive in needling than me, and she uses catastrophic terminology more than I do. We both get great effects. So that's at least somewhat interesting. And sorry, Michael, what was the very last half the sentence of that question?
It was, is IMS just a pain modulation?
Is it just pain modulation?
Yeah.
No, it's not. Because it's not just a pain modulator, it acts on the nervous system. And pain is, of course, not an input, it's an output. So IMS desensitizes peripheral hypersensitivity. So it turns down the hypersensitivity switch that exists at the muscle. This is the acetylcholine hypersensitivity. And this has been borne out conceptually and theoretically in Dr. Gunn's early work on acetylcholine hypersensitivity and the effect of, if you look at work for like Axelson and Thesloff back in maybe the 50s, we know that there is an impact of electric impulses to calm that acetylcholine hypersensitivity. And that is all stuff that is tested on a tissue that has been removed from the test animal. So the nervous system is no longer participating. So we do know that there's something going on there with maybe acetylcholine esterase, or with the amount of acetylcholine that's released from the neuromuscular junction, or in the reuptake through the acetylcholine esterase, or in the metabolism of the acetylcholine on the receptor end organ, right? So I don't believe it just moderates pain. I believe it does something much more electro and neurochemical. But of course, those are inputs that are used by the central nervous system to help create the protective response of pain experience.
Yeah, that sounds good. You brought up Lyndall's PhD. That question did come up during her PhD defense.
Oh.
You know, like basically how much of it is the therapeutic alliance building versus the pain education versus the, you know, supportive counseling, and how much of it is the IMS. Okay, next one. Would you use the same model for patients with subacute pain as you would use for pain with chronic patients with chronic pain? Do you know of any evidence that this would be preventative to developing the progression to chronic pain? If I see the patient within 1 week after their motor vehicle accident with whiplash, can you prevent this from developing into chronic myofascial neck pain? That's a fascinating question.
I just feel like I have opinions on everything. I should shut my mouth more, but I was asked that question. So Dr. Gunn's original slide states, so he's got this slide where he talks about he talks about the erosion of the human body over time. And he says it starts basically at conception and ends 6 feet under after we die. And one of the valuable things of his slide is he said that the qualities or the backdrop for what will be chronic pain down the road is actually always there. And I always thought that was a very interesting way to look at it, because again, he's viewing what is the human body as a slowly he calls it a slowly rotting nervous system, because spondylosis is continual throughout our lives. So if you want to hear Dr. Gunn's specific answer to that, you would look at it was either 1973 or 1976, his pre-spondylosis paper. It's an absolutely wonderful paper. And I think that's the one that he was runner-up for the Volvo Award on, a very prestigious paper. So you would get a good answer from that, but the answer would kind of be, yeah, the earlier you get at it, the better. And then at the last Pain Society of Alberta conference, which was a world conference this year, one of the doctors that presented from, now which one was he? He was either the Scottish physician or the American, I think Scottish. What he said, he referred to a study where they were able to find what they called the presence of chemical indicators of chronic pain in a client within 20 minutes of the start of a surgery. Now, I haven't seen that paper yet because it's like a whole lot more things to do, but that just kind of shook my mind, because that's the level we're getting at now that we've got a genome sort of figured out, now that we're figuring out the epigenome and we're starting to look at all of these other indicators. People are saying, okay, well, if we know these chemicals are associated with chronic pain, they're more prevalent in people that have chronic pain than don't. What is the body doing, and when is it altering maybe the genetic expression for the proteins that would create those chemicals, or in the genetic expression of the proteins that would split or lyse those chemicals and deactivate them? So the answer to your question would be absolutely, the quicker we get at it, the better we should be able to impact it. But that goes for not only with the application of Gunn IMS, but it also goes with the modern pain science. Like, the faster you can get to a person and get them to understand what pain is and what it is not, the better it's going to work out for you. And that's why I commented in this presentation that as a broad medical system, we were woefully late to the game by not seeing her until 11 months. In my personal clinic, if we look for some of the signs that we can easily identify for chronic pain in an MVA within 30 days. And so, just so I can prevent the next question, so some of the things we look at is a Tampa scale of kinesiophobia, pain catastrophization scale, which has magnification, rumination, and catastrophization as subscales. We look at an impact of events, an IEQ. We could look at anxiety measure or a depression measure. Those are kind of the 5 measures that we use on a regular basis. And I kind of coach my staff as to what client comments would indicate which measure to use, because each one of those measures have kind of yellow flag, red flag cutoffs that you can generally use to try to predict that person might end up heading toward chronic pain, and then maybe assisting your therapeutic intervention with a referral to like a physio like me that is weird and likes chronic pain, or to an occupational therapist, or to a psychologist, so that they can initiate that process of what we would call behavioral modification, or modifying the mindset of how a person would look at something. The mindset literature, it is also very, very strongly suggesting that the quicker we get at these things, the more robust our response is. So the answer is yes, from at least 5 different disciplines.
Good. That's nice and clear. Alex asks, what are your thoughts on the patients who get excited when they get a good twitch, even if they're hypersensitive? If your stance is that it's more aggressive, is the excitement productive as a pain modulator?
Yes. And why is it yes? Now we're getting into mindset research. So the client's perception is now being understood as intensely significant with respect to the physiologic response. So so when you look at mindset, you have a stressor that's acting on the client. That stressor has to be, if we can make this a little bit too simplistic, it has to be identified from the body's perspective as either a threat-based stressor, which would initiate a fight or flight sympathetic response, or it has to be categorized as maybe a challenge. And that challenge would be maybe more of a subdued parasympathetic rest and digest response. So if the person comes in and they're really, really excited about that twitch response, they are not seeing that twitch response as fear evoking, which is kind of like when a guru takes a nap on a bed of nails. Like, I'm not going to do a nap on a bed of nails, that would freak me out. But they seem to be quite happy. And it has more to do with mindset, which tells us that it's not just a peripheral tissue response. The central nervous system, of course, is very important. So again, I say, well, no kidding, because we only have one nervous system. We've just artificially divided it so we can communicate better. And I'll tell you about this one study that really, really was interesting for me. So it was actually a dietary study, and it was a combination between the Department of Psychology and the Department of what do they call it? Nutritics or dietetics or something like it's a word I never get right. So what they did was they took a group of people, maybe a sample size of 10 to 20, and they gave them 2 different milkshakes. And these 2 different shakes were going to be measured for the digestive activity using a single protein that we know is active in digestion. And the difference between the shakes, which was related to the client, which was one shake was kind of like high sugar, high fat, like yummy, yummy shake, maybe like a booster juice type shake. And the other one was like a boring old healthy for you, you know, vegan shake. And so they gave people these shakes and they loaded them with expectation. And then they measured the physiologic response of the enzymes of digestion. As you can imagine, the response for the shake that was high in sugar, high in fat, was a way higher expression of this digestive enzyme. Not very interesting, except the shakes were identical. The only difference in the shake was what they told the client. They preloaded them with an expectation. So I'm not sure if this 100% answers your question, but like, welcome to my world. Like, I don't have 100% of an answer all the time. I'm just like, but this is important and that's super important. And this person said that, and this person tested that. So again, I don't look at mandating that I go down one single pathway. I just kind of accept them all. And I try to add that kind of robustly to the progression of my client from this incredibly hyper-aroused psychological state to maybe a hypersensitive MSK nervous system state to moving toward increasing levels of function. And then, like, don't get me on the positive impacts of exercise, because I'll just absolutely go off. The biochemistry of exercise is thousands and thousands of papers. Same thing with the way you eat, what you eat, the timing that you eat it. All of these things are very important, and every single one of these will contribute to the, let's just call it the sensitivity of the nervous system. They're all important. And sorry if sometimes I sound scrambled, but this is the way my brain works.
No, they're all just different arrows in your quiver, right? And you can't use them in isolation.
Yeah.
Okay, so the next one, do you feel with this new research that people are predisposed to chronic pain, as in depression, anxiety, etc., or is there sort of a genetic predisposition?
Yeah, I suppose both. Again, when you look at different papers that would look at things like lifespan, health span, depression, anxiety, the predispositions are, you know, like we've got this nature versus nurture. And again, I'm like, I don't think it's nature versus nurture. I think it's nature and nurture. When you look at something like longevity, they used to think that if you had older people in your family, you were going to live to an old age. And this was the idea that it was all just genetically based. Then we started to discover what the heck the epigenome was, and that epigenome is intensely affected by your diet and by your socialization, by your job, by your marriage, by your kids, by all these things. So I don't think that we have to say nature or nurture. I think they're both. I always say, like, let's just say they're 60-40, and which one's more important, I don't know. I think that they're both going to be a contributor. There's definitely genetics afoot with people that have depressive disorders. The clients that I find the most difficult to treat when I'm attempting to treat solo practice are the ones with bona fide anxiety disorders. I think that the amount of anxiety I'm willing to be comfortable with in my client presentation is way, way higher than other physios, but that's just kind of like my nature. I have no problem with that. But when my anxiety and depression measures hit what a regular physio would call a yellow flag, I think that's okay with me. I'm willing to go 3 or 4 treatments to see if they diminish, but I have red flag values. And as soon as they get those red flag values on those measures, I seek the assistance of psychology, psychiatry, or occupational therapy, depending on the client. Some clients are totally willing to go to OT, but as soon as you say psych, that they're like, I'm not faking this. And then you have to go through but like, I'm not saying you're faking it. I'm saying that there are different strategies that are going to be able to calm down things like anxiety and depression while you and I are working on X, Y, Z. So yeah, that's a great question. And I think you can rely on some of those subjective report outcome measures, those 5 that I had mentioned. They're really, really good to go through. And there's decent literature on yellow and red flags for those. Those should drive your referrals. Yeah.
And I think we have to treat the whole patient.
And we're a team. That's the point of my presentation. Don't say that treating the periphery is old school. It's a human being there, and we have to treat, as you said, Michael, with arrows in the quiver. We have to shoot every single one of them. Now, I might have arrows 1, 2, 3, and 4. Lyndall might have 1, 2, 5, and 7, and Michael, you might have 3, 4, 6, and 8. But if all of those arrows can bring down the woolly mammoth, then it doesn't matter. It just matters that we hit him with 4. I'm sure a woolly mammoth wouldn't come down with 4 arrows, but you know what I mean. It just matters that we have a significant enough impact to change the course of trajectory of that person's pain response.
Yeah, the team-based care is crucial.
We're so much better than that than we used to. The Pain Society of Alberta conference this year, I made the comment that I've been going to that conference for about 15 years, that this year above all, it was intensely obvious that the medical doctors were not what they were 15 years ago. They were saying, yes, the literature is saying this, but they weren't acting different necessarily in their care. Whereas this year, oh my gosh, it was lock, stock, and barrel. Everybody wanted to act as a team. There was a really, really good discussion with a physician and a native counselor that do work on Indigenous populations. Oh, it gives me shivers just talking about the way they work together. I'm going to get emotional too, but I really, really appreciate that people are bringing this full scope and absolutely understanding and embodying the biopsychosocial model. Not just saying, well, you have bio, which we love. Then we have like the psychosocial, which is important, but we don't really understand it. I'm like, we need to understand that there's 3 pillars there, not 2. It's not psychosocial. There are 3 pillars there, and we have to appreciate all of them.
Agreed.
And
And so you said you're about to get emotional. Our last question, let's see if you get emotional. Nadine says, I took my IMS course a while ago when it was one, if not one of the only courses to needle. Do you have an opinion on the number of different needling courses that are being offered today?
Yeah, I think that the more opportunity we have to learn different tools and to see things from additional vantage points, the more of a robust understanding we're going to have of the client's experience. So that's the altruistic part of it. But if I was to take a look at that with a bit of a criticism, I do worry about what I'm seeing. I looked specifically at the manual of one of the therapists in my clinic that taught on an introductory course how to needle rectus capitis, posterior major and minor. I don't like that. I don't think that's appropriate. I certainly don't think that's required. And I worry about that. And I do act as an expert witness on legal cases. I just finished one up. And in this case, the therapist did a really good job, and it was a pneumothorax case. Probably ended up being a spontaneous one, but there are a lot of other cases that are not spontaneous, and like needling a rectus capitis, posterior major or minor, without even understanding if that person maybe has a bulging cerebellum. Like, I don't even understand why you would put that needle there in the first place. So yeah, I have grave concerns, and I worry about that. And it also makes me remember at iStop back in the day, we had a group of physicians from Asia that came in, and we were discussing with them what part of their medical education seemed to contribute to this idea that they just had like really, really amazing manual skills in surgery. And the answer was, well, you know, a lot of people die, and every time they die, you just practice again on the next one. And we were all floored. So I think maybe we would want to have a bit more of a conservative approach than just, you know, if the person dies, just keep on practicing, you'll get better. So, yeah.
Yeah, and I see that in the culture of the way Gunn IMS is taught. It's very safety focused and you know, experience focused, and yeah.
Well, and this is why I love that it's housed at UBC. If I were to show you the 4 videos, I have them around here somewhere, of the class that I took, it is absolutely night and day, and people are being taught a certainly safer approach, a certainly more conservative approach, but that conservative approach is based in part on safety and in part based on understanding the neuropathic model, which is the more neuropathic they are, the less you have to treat them for the proper response. When you over treat a hyperreactive system, that's like treating a sunburn with a little bit more sun. That's not the treatment. It's a little bit less sun and maybe some aloe vera.
So that's a clinical pearl for everyone. Okay. Now this is the last question. Do you have specific pain psychologists that you refer to in your practice who align well with your treatment protocols? How do we find these psychologists for our patients in our community when we're out of scope?
Really, really good idea. And that's like them asking which IMS therapist to go to. We do not have a good system to properly identify where a person's strengths and weaknesses are. So I mean, I'm lucky. I have one, starting next week, 2 occupational therapists that are chronic pain OTs in my practice. I constantly educate people around me to think about these things and use these outcome measures to understand when there's the possibility of something going out of your scope. And then in teaching them about those measures, I say, you know, I try to teach people when you get a really high TSK, that's probably great for physio. When you get a really high IEQ, that's probably someone you're going to want to get into psychology, and maybe we have to have more conversations with the OTs to see if that's in their purview. In my opinion, it is. So I think you have to start understanding that it's OTs, counseling psychologists, and perhaps psychiatrists that will be involved. If you don't know which one to go to, what I did in the early day was I literally just started listening to some of my clients. And when they told me they had a good psychologist, I literally would phone them up and I'm like, do you mind if I come over for lunch? I'll bring some food. I need to know what your approach is, what you hope to do, because I think I might want to refer to you. So that's laborious, but I don't know another answer. That's what I do. When I'm going to start referring to people, I visit them. I mean, these days we can do it online, so I get to save the travel time. And then over the last 25 years that I've gotten more into this area, I've just kind of started to collect those people around me. I understand which chiros I'm going to use. I understand which massage therapists I'm going to use and which psychologists I'm going to use. And then whenever possible, I try to have them in my clinic. So, yeah, that's probably not the answer you want. You're probably saying like, hey, if you get this OT that's an OT with a PSA, they're probably the right ones. But you can ask them what type of certifications they have and what type of models they use. And I think every once in a while, go to a pain science conference. They're not as scary as you might think. They are not boring at all. They're super, super interesting. And when you go to these multidisciplinary pain conferences, it'll start to become abundantly clear what direction your referrals should go in. And as I mentioned with those 5 outcome measures, if you just start using those and just read what the questions are, like a question on a TSK might be something to do with hurt and harm. These are things that physios really understand. So you'll get that one right away. Things on a depression might start to ask questions about maybe feeling like they want to distance from society. So when your patient says to you, well, I don't even go out anymore, it just all pisses me off. I'm like, okay, so we're going to start with a depression score, and I'm going to see what it is. And the anxiety would maybe be more on the worry side. Like I worry, well, what's going to happen? Is this going to get worse? Does this mean that if I have this much pain at 30, am I going to be like completely non-functional at 60? I'm like, oh, yeah, anxiety score. And then the PCS is the rumination, the magnification, the catastrophization. Those are the people that are like, so if you can explain what your pain is on a scale of 0 to 10, 0 being no pain, and 10 being the most excruciating pain you can imagine, they're like, oh my God, Cory, it's at 15. Okay, so we're going to do a PCS. Like you can start to identify which of those measures are you're going to use. And then we get to stand on the back of the giants that created those measures by using their yellow and red flag as a template for when we're going to refer.
And just to follow on that, someone just asked if you could actually just list those questionnaires that you use in your initial assessment, or is that available on the Pain Made Easy site?
I can easily list them, right? So the TSK, Tampa Scale of Kinesiophobia, it's a great one for rehabilitative people to use. There's an anxiety score and a depression score, so that's the PHQ-9, and the what's the other one now? It's PHQ-9. It'll come to me in a sec. The catastrophization one is the PCS, pain catastrophization scale. Why? I just what have the there's an anxiety and a depression one. You know what? We can put them in the notes for this if it doesn't come to me right away.
Is it the G87? That's
GAD-7. Sorry, general anxiety disorder, GAD-7. And
Great.
the IEQ is an impact of events questionnaire. That's one from the Sullivan lab as well. They've identified that people with a really high measure on an IEQ go to chronicity more often. They have yet to measure and quantify whether or not that number is modifiable, but is actually a really, really good number to know. My personal opinion is that it is modifiable, but Sullivan hasn't put any research on that. And I just attended 7 hours of his talk about 3 months ago. So those are good ones. Did I mention those right? So Tampa scale of kinesiophobia, the GAD-7, the PHQ-9, the PCS. I feel like there's one more. Oh, and the IEQ.
Yep.
All free, all available. I just have them listed in my clinic. On my Instagram account, I actually go through them and I present a couple of them because I do have my own summary sheet that we do present as a part of Pain Made Easy that shows you my yellow flag, red flags, because a lot of these things are in development and they don't necessarily have really neat and tidy numbers. Like the kinesiophobia measure, it's just, higher values mean more kinesiophobic. It doesn't really tell you yellow and red flags per se. So sometimes you have to just kind of use those scores and get an understanding of what that means and which numbers you tend to be able to effectively modify. If you can't modify them, then that should generate a referral as soon as possible. Red flag ones for anxiety and depression are almost always suicidal ideation. So as soon as someone mentions that, even if they mention it in jest, I kind of jump on that with a couple simple probing questions. And I've taken a couple courses in that with mental health first aid. There's a mental health first aid course that's really, really good, run by the national organization. So that might be mental health first aid might be a good way to start if you want to get a little bit of a peek behind the curtain on some of these measures.
Yeah, and it does make sense to jump on that. Okay, well, I think we're done with our questions. So Cory Choma, thank you so much for yet again sharing all your wisdom and enthusiasm and expertise. I really love your approach, and you can tell from the questions and the feedback that it's already been well appreciated. And thank you everyone for joining us. We had a really nice turnout again this year, and it's really nice to host these and share these. So and thanks to the organization from the Gunn IMS program here at UBC. Okay, thank you everyone.
Thanks, Mike.